Well, thanks to the organizers. Good afternoon to everyone. We will just go ahead with the abstract discussions. So, initially with the case, a 37-year-old lady with a left breast cancer, clinically T2N1, triple negative. So, there's no significant family history and family is complete. Now, here, if I may ask my medical oncology colleagues, Smriti ma'am, what, as per the abstracts discussed,
Yeah.
especially in context with the Panther trial, we have the data for the dose-dense docetaxel over there. So, what is the usual regimen? I mean, most of the times that we.
Yeah, so in triple negative, we do go for the dose dense, as shown here. Only thing is, my concern is about the dose dense docetaxel. I mean, that is a little hard to give, as it was given in this every 2 weeks. But otherwise, whereas the AC is concerned, it's always dose dense AC. And the one that I usually follow is dose dense AC and weekly paclitaxel in triple negative.
Come to
And
the carboplatin discussion later.
Yeah, and so carboplatin, as I said, that is now there's a lot of evidence for it use here.
Dr. Randeep?
I think keynote 522 is the regimen. Only thing is that a paclicarbo, I will be using platinum for a 37-year-old young female, and the trial goes to the TMH trial, and from the group of Sudeep Gupta sir is that there is an advantage, and that is actually a huge advantage in EFS and OS in a young female node positive. So that will be the baseline regimen of paclicarbo. Taking care what sir did, we have realized in the practice of restricting the numbers. It's very difficult to complete 12 cycles of paclicarbo with a dose dense EC. And the second is to add immunotherapy. Of course, in this setting, it will be pembrolizumab to that backbone.
So this was the Panther trial. This was discussed, and we all know that dose dense definitely is here to stay. The EPC TCG meta-analysis, but there was this, lacuna that HER2/neu and HR therapies weren't quite there, were not regularly used in the studies which were analyzed in the meta-analysis. But the Panther trial did have the, all the patients getting the HR as well as trastuzumabs, if in case the receptor was positive. The dose dense strategy, as you can see, this was all completed in a period of 15 weeks, and more cumulative dose in a 2-weekly docetaxel design. So they realized that yes, there is a definitive benefit in terms of EFS, 3.7% absolute benefit, and of course that those patients who were getting trastuzumab were also getting benefited. So the dose dense strategy was validated. So the questions over here are that what about these key parameters? It is an established strategy, but in your practice, yeah.
If you go to the previous slide, actually, the people who use anthracycline and taxane-based regimen with trastuzumab, I think that forest plot, though the numbers are only 60 or 70, you can easily see that the diamond is too much in the favor of dose dense in the HER2 positive patients. So I think those who are using not TCHP and they are using ACT type of backbone chemotherapy with HER2 drugs, this forest plot makes importance to them that the HER2 subset was being benefited more with the dose dense as compared to the TCHP subsets. Because many of in the previous panel discussion, 2 or 3 panelists wanted to go with the ACT type of regimen.
When we use chemotherapy in triple negative now, especially with pembrolizumab is given every 3 weeks. So, how do you do the every 2-week regimen? I mean, patients will not come again and again. The other question is, even with the HER2 targeted therapy, I mean, most of the times if you're doing TCHP, you'll give it every 3 weeks. So how, I used to always give dose dense, but now that I'm using it with these treatments, it becomes a little bit of a scheduling conflict, and I've gone back to every 3-week chemotherapy.
One way could be, sir, pembrolizumab has been given 6 weekly as well in other tumors. We do not have data to that, but if we have to integrate, I mean, one way could be And weekly Pacli could anyways fit very well into any type of improvement. But 6 weekly is another way to think at it. However, not many patients are getting Keytruda with us. So dose dense Pacli, Pacli carbo with dose dense EC is what we follow routinely. And if we have to give Keytruda, then it is a challenge with EC. But one way to think at would be 6 weekly, 400 milligram would fit very well with it.
If immunotherapy is not going to be used as is most of the time, then I would definitely use the dose dense and also with the carboplatin. So I would go for their carboplatin with Pacli. But if we are going to use pembrolizumab, then I would stick to the KN 522 protocol. I wouldn't digress from that. Though there is another trial which was mentioning the dose
Modified.
dense with immunotherapy, but I would stick to KN 522.
So the other point is, if we are using a dose dense with immunotherapy, there could be febrile neutropenia and antibiotic use. And we also seen that antibiotics can adversely
But
impact
if
the
you look
overall.
at the dose dense initial data, the effect was not actually higher in patients
In our
who received
situation,
dose dense.
we should be
It was
aware.
actually lower because GCSF was used prophylactically.
Yeah,
If
despite
you look at
prophylaxis.
the initial trials with the dose dense things, it was lower, the infant rates.
So just to make a comment here, I think a lot of these dose 10 studies were older studies, well before dual anti-HER2 and pembrolizumab became available. The question is, do you really, when you integrate these high-end antibodies and immune checkpoint, do you really need dose 10s? That is the question.
With HER2 new, we have the answer, ma'am, that it is actually impacting over there positively. But of course,
So,
the
ma'am,
complete
I
answer with
will
pembrolizumab-
put a contradictory comment that do you really need immunotherapy if you are doing a dose dense? And that
So it
comes
could
from
be-
that
it
comes
could
from
be
the
taken
datolizumab
both
trial.
ways.
When they discussed the Atizo trial, 68% of the patients were dose dense,
Right.
and 25 or 27% went on capacitabine adjuvant.
Hmm.
So, if you follow the dose dense adjuvant capacitabine as a Createx and then Olympia, does really Keynote add
So
something?
that-
Because Keynote avoided everything.
So
Dose
I'm
dense,
not
creatine.
very happy with pembro and triple negative, I'm being honest. I've had fabulous responses with neoadjuvant platinum in this setting and in a dose dense. All right. It's also the TCHP we are talking about. So there, I think doing it 3 weekly with a dual anti really doesn't make sense to put any kind of dose dense in that picture.
I mean, the context of dose dense mainly remains relevant for triple negatives and even ER positive. So our take is that if the patient, we are not adding a new agent, we are not adding cost. If there are no adverse events, you give the first cycle with an intent to give a dose dense. You assess at 2 weeks. If the patient is well tolerating, go ahead. Nothing is, I mean, we don't lose on anything. We are not adding to the cost anything. So why not? Right? The only thing is by giving Keytruda along, you lose on one cycle of Keytruda if you give it dose dense. Right? And I mean, no one can answer. These are all pragmatic questions that how do we combine these? But we'll move forward, I think, in interest of time. So dose dense still remains, I think, how do we mix it up? It comes up along. Till 2029, I think, till we have pembrolizumab coming in the market as biosimilar, dose dense would stay. And like this is the 10th anniversary of Year in Review, I would congratulate Dr. Sudeep Gupta. Like sir, I think carboplatin has always remained for 10 years in the slides for discussion on triple negative. And we have another trial now. I mean, look at the way things are moving. We are still not convinced with. Some people are still not convinced with carboplatin. Before we move on to the discussion, amongst the panelists, just a show of hands, who would not give carboplatin? I think that's a repeat question. But anyways, in such a patient,
I had
37-year-old.
previously committed to not give carboplatin. The previous poll question by the previous author, I said I would not give the carboplatin.
Wonderful. So we'll ask the question first to you. This was the trial. Some differences between the Tata trial and this trial is this was AC followed by tax carbo, and this was 8 cycles. This was 80 milligram per meter square. Subtle differences, but the results remain the same. The PAT-CR increases, the OS increases. Just one point: the distant difference, if you look closely, was 8.8% versus 10.4%. So that's a 1.6% difference in the distant recurrence. Just a pointer. And then if you look at the OS, again around 3.7% difference in the OS. Adverse events were fine, quality of life is fine. And coming to the slides from Tata study, subtle differences. But more or less, we agree that both the trials, if we combine, give us enough power. If we combine the individual data, this would definitely give an OS without any problems. Now the problem is age important? 50 years was found here, and if you look at the forest plot, 50 years again, somehow we are seeing is moving towards that. So maybe we can start with you, sir.
Yeah.
With carboplatin, you said you would not give. So do we need another trial, or even a Cochrane meta-analysis was published last year that said there's a definitive OS improvement?
So I would say I would not give it in all. There are definitely selection criteria that we need to be aware of.
Which patients you would not give?
I would not give in patients who are not fit for that, obviously.
That goes out, that goes unsaid. Like, okay, we are not giving in those who are not fit. But if a fit 37-year-old female like this, T2N1, presents to you in the clinic, she can't take Keytruda, and now you have the option of giving carboplatin or not, would you or would you?
I would discuss the option of carboplatin and the logistics that are involved, the toxicities that are involved, patient's preference of hair fall, and all the other things taken together.
Hair fall would be more with taxane, so
Yeah, okay.
losing all hair anyways.
Yeah.
No, nothing adds with carboplatin.
It does add cost to the treatment, and it doesn't translate consistently into the overall survival benefit. We are only looking at PATH-CR as consistent, impact in the trials. So I would discuss it, but I wouldn't push it if the patient is worried about the toxicities.
Dr. Randeep, change in
See, I think for a young premenopausal patient, I would use it in a weekly fashion. For someone who is like a 3 centimeter node negative or more than 60, I mean, an early breast cancer and going postmenopausal, definitely more than 60, I would not add because I will be compromising my EC and taxane regimen in an elderly more than 60
That's
patient.
another question. Do you start with EC or do you start with tax carbo? But starting with EC, you are sure that anthracyclines is received. And then when you move to tax carbo, you can drop carbo if there is toxicity.
Usually we do that only. We start with EC
Or you
and then
start
carbo,
with
you
taxane.
modify your doses going from like 1.5 or you could restrict at 8 or 10 cycles. Even sir restricted at 10 in the TMH. 8.
100 milligram per meter square into 8.
But it was 100 Packley and carbo 1.5. Yes, but it was 100. Yes. So you can restrict the number of cycles. That is always better because you don't want to compromise your anthra any day in a triple negative breast cancer. And even taxane, yes. So you can drop carbo. That is the best. Most of us do that only, that you start with an EC and switch to taxane carbo and modify the regimen.
We take on the 3 weekly carboplatin. So here,
See, there is a data, but
So
I
you
have.
had both the options.
I'm.
Carbo could be 3 weekly and weekly as well.
So I have not used it, so I can't comment. But yes, there is a data here as well as in other trials where 3 weekly carbo with a weekly taxane regimen has been used. But in my practice, actually, I have used always Packley carbo as a carbo 1.5 or 2 in a very young patient. Weekly.
So the other point I would try to make is if the response is excellent with EC and there is a clinical response and there is a clinical complete response, would you still go ahead and escalate it with carboplatin in the second part of the taxanes?
That's another thing, but we know that clinical response may not actually correlate. We are still struggling with an MRI correlation to a PATH-CR.
In triple negative, there is
In
triple negative there is a good correlation, right?
but no. So
it's
what?
good, but it is still not, still not in practice. Still, it's not a 99% thing that you see a clinical response, you're sure about the PATH response. So I don't know how this clinical thing. Sometimes it's not very specific that once you see a clinical complete response, you get a PATH response. Anyways, moving ahead, what about adjuvant? So another thing that the Pearly trial had adjuvant as well. Now, do you get confidence in a by chance operated patients? We still get patients who's a T2N1 disease operated upfront TNBC. Now, would you include carboplatin? The same patient operated upfront, now in your clinic.
can take from ma'am.
Yeah, so the patient with T2N1 should ideally have received neoadjuvant, and where
But we
you
keep
would
seeing
use
this in clinic that-
carboplatin. Now the same patient with that high risk is going into adjuvant. I would still include carboplatin because they have diverged from what was the ideal
This
treatment.
trial actually included such patients who were operated upfront. That subset was there in the Pearly who were operated upfront and then given carbo. So we maybe, and the next question is, what about ER low? Although we will be discussing more about this, but specific to carboplatin, ER 4/8, ER 3/8, common patient is 32-year-old. How do you now think about it?
Dr. Avinash.
There will be a very small subset of patients, like 6 to 7%, who will fit with less than 10% expression of ER. So obviously, there's very limited data for people to select for or against. But the kind of presentation we have seen couple of minutes back, I would tend to kind of treat these cohort more like a triple negative breast cancer. So I will be using dose dense, and I will probably try to incorporate platinum as well, especially in those patients who are not able to get a PAT CR. I would try to, for example, if they have used dose dense anthracycline and someone does a surgery and didn't found it to be a PAT CR and they couldn't take IOs, then I'll prefer to give taxanes and platinum together to them.
If that patient did not achieve a PAT CR, then
I'll escalate with adding platinum over taxanes in adjuvant. If not, PAT CR has been received.
Put this. I mean, CreateX did include a subset of patients that were ER positive, but for carbo, it failed actually. There was a non-inferiority trial for triple
Yeah, but we are
negative.
talking about low ER. So we are not sure about how it will play with, but I'll go to with the triple negative subset. They behave more like a triple negative. So I'll treat them with a triple negative regime because this is a very rare subset for which we can't find exact data. That's not like hormone positive. They are more like a hormone negative kind of.
Even in the triple negative subset with residual disease, patients were randomized to receive capecitabine versus carboplatin. That was a non-inferiority trial, not even a superiority. And that failed to show non-inferiority of carboplatin with over capecitabine. Yeah. So how do we take this? So it's not effective in TNBC, so it's unlikely to be effective here.
I'm not sure about that.
Probably. But yeah, it's a
Yes.
clinical conundrum. Even this subset you would see is a heterogeneous comp. 1 to 9% could be weak, moderate or intense staining. So it could be 3/8, 4/8 or 5/8 as well. So how do we go about this? This remains as a clinically difficult situation. Patient who's 23-year-old may be treated differently, like otherwise a 60-year-old female. So all those things would come into picture.
So just a quick comment on the third question actually about the adjuvant use of carboplatin. And if the patient is BRCA mutant, would you proceed on to use the olaparib versus escalation of the chemotherapy? I would probably I would use the olaparib rather than
Olaparib has a
escalate.
definite OS benefit. I agree on that olaparib should be offered. Carboplatin, if it's an N2 disease or an N3 disease treated upfront, I don't know. I would still kind of give everything. I know this patient is going to come back.
I mean, going with the data
patient is fit.
perspective, if
So
there
even
is
in the
a,
Olympia trial, around 20% patients, if I'm not wrong,
Yes,
did
they
carboplatin.
received
they
carboplatin.
did receive.
They receive.
They received. So I
yes.
would give AC Pacli carbo followed by olaparib for 1 year.
And they did benefit also.
They did benefit.
They did benefit. It's a subgroup, a small subgroup.
I always get boggled down by the fact that all trials are saying ER, PR less than 10% and more than 10. And all over the country in India, it's all red score, 1 upon 8, 2 upon 8. So how do you correlate? Is it 3 upon 8 less than 10 or is it 4 upon 8 less than 10? What is it? I mean, all the trials are saying less than 10 while we are using all red
So I
score.
think like all other things in
And
life,
the
it's a
pathologists tell
continuum.
me you can't correlate.
Actually, to her question, there is one article in JCO which was put forward, and less than 4 is something that they put as 1 and less. But there is no direct correlation, but there is a good correlation of the AllRed and the scoring system, and it happened 6-8 years back. That's it.
It's a continuum.
So
we know.
4 out of 8 and below is something that
is-
they considered low, less than. So that's the best I can think of as a publication. My answer is different. I came for a different point. So I think the role of carboplatin in adjuvant only comes in when someone has triple negative has been operated and has come to you. So you give a carboplatin. That's what Pearly told us. The carboplatin adjuvant helps. If someone has received a proper neoadjuvant with or without a pembrolizumab, I think there is no role of a carboplatin in adjuvant because that trial has not
I
addressed
might
it.
rather discuss creative.
I will go for create. I'll go for capecitabine, and the acrine data which you told was a non-inferiority, and they showed both are equal. Toxicity was more for carboplatin.
Did not show non.
It was both are equal.
It did not show.
I'll pull up. It's
It did
acrine.
not. It was acrine, but it did not. It failed
So
to
I
show
think
non-inferiority.
I
The best I remember.
okay, I may be wrong.
I
I'll
may be
just pull
wrong
up.
as well, but
So, but what
the
I
best of
remember.
my knowledge, it did not show.
Okay, what I remember both were equal, and there was toxicity more towards platinum. That's what Off late, I can remember that's Acrine data set. But the data set, I think someone showed. Will I use IO in the
We'll
low?
come to that, sir, in a while. So we were still discussing common man therapies. Now we will move to rich man therapies. Now we have all immunotherapy discussion from here on.
NSABP B15, this was discussed, and neoadjuvant chemotherapy with atezo. It's almost a similar trial design as the keynote 522. So SABCS 23 last year, it was like the Alexandra trial, which was actually not a positive trial, and the authors were actually looking upon NSABP B15. So here is the EFS, and which was negative, and so the PCR, now if you see that in the atezo arm, there is almost 63%, not a fair thing to compare with the keynote, but it is almost like 64% in the keynote. But then the comparator arm, the actual chemo arm is also doing like, well, 57%. There in the keynote, it was around 51%. So overall a negative trial, but almost a similar trial design. Something is not really identical. Another study of avelumab in escalation strategy, almost like a CreateX. So here, the primary endpoint is not met, the DFS, but the secondary endpoint, overall survival, there was an improvement. Though this was not a hierarchical analysis. Is it, when we are looking at avelumab and atezo, so it's a PD-L1 inhibitor, is the drug basically something to do with the drug when we are talking about why?
So I think,
Dr. Pandey.
So these results basically in adjuvant setting it has failed to show any benefit, while 522 has shown benefit, but more in the earlier lines. Maybe it's a disease biology which is here having a role in getting a different outcomes to similar kind of circumstances, because patient cohort in all these studies were quite a bit different. For example, in BRAVE study, it had patient who had residual disease or had a recurrent disease, and keynote obviously had de novo patients. Maybe something to do with that. The exact answer is difficult to decipher whether the drug is at fault or the testing is at fault. So I don't know there is one straight answer to this question.
So I think we have trials for every situation. Somebody has not convinced himself.
But another interesting thing with ABRAVE was, it was an academic trial.
Yes.
They were over ambitious with hazard
have this
ratios, say
escalator-
0.6. We know how academic trials are kind of done with over ambitious results to reduce the sample size, constraints of budgets and all that. Hazard ratio assumption was 0.6, sample size was lower. Still, there was a difference in the DFS of around 5% absolute terms. But it failed to meet because it was, not powered enough to take this statistical, this absolute difference into statistical terms.
Yeah, I
If you
think
look at
13
exploratory outcome, DDFS, distant disease-free survival, there is a 7.5% absolute terms. OS, there is around 8%
8.5%.
difference. How do you take this into? Is this because of multiple testing that we are seeing? Or it was just that this had 500 patients, keynote had 1174 patients. Had there been more patients in ABRAVE, or had it been brave enough to answer then?
So I think there is a heterogeneous mix of patients. There are both
But this is
stratum
a
A,
patient
stratum
that
B.
we, I think, struggle. Once keynote 522 is applicable to all patients, then I think this trial would anyways be irrelevant because all patients would have received Pembro by then. But now this is specifically for patients who have not received IO, in new adjuvant, have residual disease. This is the tougher of the trial. We know. Can we offer it if a patient comes to your clinic? Would you think of it or do you totally negate this?
No, I think this is an escalation strategy for those patients who have a residual disease post-surgery.
But are you convinced with the results?
Yes, to an extent, saying that the overall survival benefit and DDFS benefits cannot be ignored.
But how do you take it that the primary endpoint is not met?
The
and
primary
secondary
endpoint was
is
too
not?
high for them.
Because of the
13.6% difference in
immunomodulation
DFS is
happening.
never going to be achieved.
Randeep?
So my comment was that the differences in the statistics, if you talk about ABRAVE, is 13.6% DFS with a 500 data set. I always remember Sudeep sir, he says that you increase the number of the patients in the trial, and then what happens in the breast cancer is you take thousands of patients and then similar benefit you
That's
see.
an affinity.
So so that is what is relativity here, that the numbers went from 1000 to 500 and their DFS went from 5-7-8% cutoff to 13.6%. But you are very rightly said, it shows that the drug is important. It shows that statistics is important, but I can't use it because
But
this
avelumab
drug.
in general, like atezolizumab has failed more.
But I can't use it in the practice because of the statistics. Now going to the atezo trial, there, if you go back, this is also not same. Though here it is the statistics compared to keynote 522. There it is the trial design of atezo. If you go back to atezo, the slide which was there, just one more back, you see, one more back here, one back more.
One more.
So it's 68% that is not shown here. 60-65 were dose dense. 49% have received capecitabine. In the slide they given it. So that is what is
Even in
maybe
ABRAVE,
making a
that
difference.
was difference. It was 24%.
And even in ABRAVE, 24% received
There was a
capecitabine.
6% difference in capecitabine. Whether that is accounting for the
That
difference,
is-
we don't know that.
So that is what I'm saying. Before saying that the avelumab is weak and only Keytruda is the king PD-L1
I have
inhibitor,
one
we
more
shall
question
rely,
for that.
give some relaxation to the stats and the trial design and give some importance
love
that the
discussing
investigators are
trial
using a more
designs.
practical and more scientifically robust trial design here.
Yeah,
See,
one small point.
Where,
Madam has a point.
this
Dr. Dharti.
point about avelumab, I know that the primary endpoint was not met. But, in practice, we see a lot of patients who should have received neoadjuvant pembro and chemo, but, and they are high risk, but they have been operated for whatever reasons. And in those situations, I would definitely take the benefit of avelumab. And because there was a 30% reduction in the risk of progression. So I
The
would
drug has a place.
definitely, those patients I would offer everything because, once they recur, you don't have anything to
But we
go
don't
by.
know whether
So
capecitabine
in
was
this
offered equally.
particular subset, those who should have received neoadjuvant but have been operated and they have, gone on. So I would, and they're high risk, then I would take this data.
we
Though
have
the
another
primary
trial.
endpoint was not met. But, in some of the immunotherapy trials, you do have that EFS is not different, but you have the OS, which is
So ma'am, the keynote 522, there is if there's a residual disease post chemoimmunotherapy, the EFS is only 70% compared to 94% for those patients who had a PAT-CR.
We're coming to that.
Yeah, would there be a concept of switch maintenance to avelumab instead of continuing with pembrolizumab?
We do not have any data and we do not recommend using this strategy till we have any other data.
Another thing I'd just like to point out that even in KN522, there were 40 patients who did receive capecitabine, but then they were taken
less than
off.
1,000.
They were not taken into consideration.
Yeah, so coming to long-term data of pembrolizumab was presented, and now we are convinced that it works. There were some issues that capecitabine was not allowed, olaparib was not allowed. Those are certain issues, but now we have an overall survival update, and we are now seeing a difference of 86.6 versus 81.7%, a 5% absolute difference, very similar to the RCC keynote 564. Again, a lot of controversies out there as well. So coming to certain questions, the meta-analysis also said the same thing. So what is the optimal chemotherapy backbone? So of course we would like to stick to the keynote 522 this thing, but we already discussed how can we integrate dose dense, and we have discussed. And two questions that come to my mind is that would come to everyone's mind is that do we need to continue foliar pembrolizumab in patients experiencing PAT-CR? Are we stopping in clinical practice currently? On to you.
So, if you look at the data, if you look at those who achieved a PAT-CR, then there's no difference in survival between the control arm, which
Are we
did not
stopping
have.
pembro here?
No, can I just, tell you that if you look at PAT-CR, then those patients, there was no difference between those who received the adjuvant pembro and those who did not receive. So it was equal to chemo. So I would, if I go on KN 522, if there is a PAT-CR and the patient is not tolerating or as having toxicity, especially endocrinopathies, which are going to be long-term, and especially adrenal insufficiency, then those patients I would discontinue the pembro. But if somebody is got residual disease, I would continue the pembro, and then
I think so.
add on other things like capecitabine. You have phase 2 data. You have data of combining olaparib with immuno.
So I think we'll get a straight away answer to this question in some time. In one of the year-end reviews, we would discuss this. But another question that we discuss in all the panels is, Dr. Pandey, to you, are you okay combining capecitabine or olaparib in patients who have residual disease after giving keynote 522 regimen, BRCA positive, BRCA negative, How do you combine?
KN5T2 didn't had these subset of patients they have excluded in the final analysis. But if this not in PATH-CR, if not in PATH-CR, I would tend to give them a benefit, especially if they are BRCA positive. I'll use olaparib in them. And if PATH-CR is not there, I would tend to give more capecitabine because I know that this disease residual status is still not achieved, PATH-CR is not achieved. Obviously, this is a bit debatable, but I would tend to give rather not to give.
Most would give. Anyone who would not offer this combination, if there is a residual disease, are we all practicing adding olaparib / capecitabine? They are convinced with that or not convinced with that? No phase 1 data.
But
It
you
does not
have-
allow, but a patient has say 10 lymph nodes now in your clinic. You would combine. I mean, there's no other option. Vis-a-vis probably a
Yeah, there is phase 2 data on this.
Yeah,
There is
they would
phase
have
2.
There is a phase
benefit of taking Pembro over and above as well.
There
Not
is-
PATH-CR benefit with Pembro.
There is phase 2 data of combination of immuno with cape.
No. One of them and Pembro. Ila plus K plus
yes,
Pembro would be a lot of
I mean,
If the patient has a
wonderful.
germline mutation, I would give olaparib. Yeah, but if they're negative,
all
I would
agree on
give
that.
cape.
I mean, that is more of a like a targeted therapy. Now you have that BRCA positive sitting in front of you, so you can offer a BRCA positive, a combination of olaparib and those who are BRCA negative, they go on a cap and
There was a
Pembro
Keeling
regimen.
009 study in metastatic setting where they gave a maintenance olaparib plus Pembro after initial chemotherapy plus Pembro. There was no PFS and we'll discuss it some other day.
So moving forward to Promenade trial where Pembro was there in the ER low and being treated like triple negative. So this was in France. So if in France we are, looking the French are treating less than 10% as triple negative. So they achieved, the PCR was around 75% over there, higher than what the keynote would be, 64%. So coming to a case-based scenario, and a 45-year-old lady with a clinically T2 and N0 disease with a ER low, 4/8, PR 3/8, and a high KI67. Now, what would you do over here? Would you go for upfront surgery? This is very much operable. Yeah. So, Dr. Aparna, intrinsic subtyping, does it play, importance over there? The basal type?
So if you look at the ER low in particular, which they are treating as triple negative, I think the only between a classic triple negative molecular subtype and our HR positive, the ER positive subtype, it's the basal-like and the HER2 enriched, which is the only intrinsic subtype that is overlapping between the two. I do know there's some data with, I think it's PAM50, yeah, but I think I would not be recommending it at this point. I think the data is not strong enough. Sorry.
Okay. So, what about the approach to treatment? I mean, neoadjuvant or surgery first?
Should have had some surgeons here on board. Do we have some surgeons in audience? No. So we are safe then. Probably we would all agree then.
Can I give you a
Oh, we
more,
have ma'am, so.
can I give you a more difficult problem? If the patient has T1, 2.1, 2.8, after would you do surgery first or would you do?
We'll first solve this, ma'am, and then we will make it tougher.
I thought we were operating less than 2 before.
Let us all agree on this one. Are we all doing an NACT or are we doing then? Oh, ma'am,
Okay,
we also
4
have-
centimeter. I don't have the nodal status here,
N0?
but she is ER low and she's HER2 negative, K67 high. I would give neoadjuvant chemo here.
If it was 2.1 as ma'am said,
No, if it was a 2 centimeter node negative, I would discuss with the patient and see whether she would.
we don't have a
But yeah,
clarity.
I don't completely
We know
agree
where
that
discussion
in a
with
node
patient
negative,
goes.
in a node negative situation, but she's a high K67.
Absolutely.
I
I'm
would
totally
be
with
inclined
you.
towards a neoadjuvant because I know there is capecitabine which will give her a benefit.
Definitely. Any other thoughts on this? Anyone who would consider surgery first? We'll make it tougher. We'll keep on that slide. We'll make this lady a 60-year-old female. Any change? We'll make Ki67 go to 40%, 20%. No, we all will give 65-year-old surgery first. No?
Yes, surgery first, because I think I always think about it. I mean, if I can do a good BCS and I can make her fit in 2 weeks' time or within 3 weeks' time to give the chemotherapy plus whatever immuno, I mean, 3 weeks is not going to make a great difference to my mind.
Dr. Randeep, your thoughts on
I agree with Serene ma'am that yes, if the BCS is possible and I have some doubt about the tolerability to chemotherapy, I would first operate upon, especially in an elderly female, a younger female with a Chi of 80% and a size of anything more than 2.5 centimeter, I would like to give neoadjuvant within a younger female, a postmenopausal 65 and size going
Let
2,
me give
2.5, I would like to go with surgery first.
So if
let
someone-
me give one more twist to your twist.
We only we are allowed to get that.
No. So if it's a small tumor, T2 is small, okay? 2 centimeters. We're sitting on that, literally on that line, 2 centimeters. She's a high Ki67. Now, if you look at the pre-chemo predictors of response, smaller the tumor size, better the response. High Ki67, you expect a better response with chemo. A low ERPR. So in this situation, I may end up with a complete response if I give chemo. The chances that she would move on to something else, capecitabine will get a benefit, may be much less. So I would want to discuss this and maybe individualize the patient
You're on the
treatment.
same page, ma'am.
Yes, so that's what.
I would
it
also
all
offer
depends.
NACT first approach.
But Atul,
Even if it is
Atul, one more
2.5.
point is that we have to remember before escalating that if it is a 2.5 centimeter tumor and maybe Chi not 80, maybe Chi around 20, 25, there will be always a role of doing oncotype once you operate upon this patient. You can't
Once
just
you operate,
discard those patients at all that you will you will give chemotherapy to every. So someone who has a borderline Chi, I'm not going with an 80% Chi, but someone at 20% Chi with the scenario of 2.5 centimeter, with this all subset remains same in a 50-year female or 55. There is somewhere a thought process of omitting if the patient wants to omit, or you may able to omit chemo. So we shall not
Would be
totally
tough in
forget
such
that
situations.
borderline. This is a
Not
very
su-
high KI.
Not sure how many such patients would actually have a lower risk of recurrence score.
How many such means what?
Yeah, low patients.
So a 2 centimeter with a ER of 20% within this ER 4 by 8, PR 3 by 8 and a Chi of 20 with a 2.5 centimeter tumor and a 55, there may be some 5, 6, 7% patients who may avoid, or rather 10 to 15% who may avoid. So it is a very individualized thing. We can't just stick to this scenario. It depends.
Even before the French data, I would, if French data is not there of low ER, I think this same slide was reviewed by another pathologist. He or she would have said TNBC only. I think even before French data, I would have given.
No, we are assuming that all pathologists have agreed and the consensus score is 3 by 8, 4 by 8, and then we are here. The patient has already taken 3 pathology reviews. This is the agreement. Even then, we would like to treat her as probably a lot of factors would come into picture. The age, Ki 67, if that's a 30-year-old female, and we would agree on treating her. But the question comes on carboplatin and pembrolizumab.
So my question is very simple is Ki 67, what is the cutoff in such patients?
No cutoff.
You know, you don't have a cutoff.
No cutoff.
So if you have 20%, and do you believe to give immune checkpoint as per the French data? Yes, no. For this year 1 to 9.
Not only I could.
No,
But
the
that's what we are asking
panel. Because this is opening something else. So
Yeah,
my point
it's a clinical conundrum for sure. I mean, it's not as easy as straightforward.
no, is
that we say.
like Smriti madam is there or sir is there? Are you convinced about giving the 1 to 9% as per the French data immune checkpoint 522 like trial?
That's what our next question was.
Okay.
That
I'll last put it more little bit. If there's a 20-25% Ki 67 and somehow has come to you with Oncotype DX,
up without surgery.
has come to you with Oncotype
you
DX
said
on a
without
biopsy
surgery.
specimen.
1 to 10%.
It
you
happens.
said.
It happens. A lot of people, not to Bhopal, but in Delhi, it does happen. So, if they come down to Oncotype DX and it's a low,
Fortunately, it does not happen with me. Pre-operative oncotype DX. And I wish it doesn't happen.
Agree that if
I wish
we are
that
seeing
patient
that
doesn't
all
come to
those
me.
factors are going
I
towards that,
think-
then upfront surgery may be fine in that case.
I would take 1 to 10% as triple negative, and I would have hesitated to give immuno, but after this data, which has shown that those patients do
ma'am,
benefit,
so do you not give adjuvant hormone therapy for 1 to 9?
of course I give, because see this ASCO guidelines and ESMO guidelines, they are taking 1% cutoff. So actually my question to the audience is, they say that less than 1% is low, but the French and many other countries take 1 to 10%. I have seen that the response to endocrine therapy in 1 to 10% is very low.
In a
So
metastatic
I
setting.
would treat as triple negative, but not deny them endocrine. It was shown that the American cohort,
But addition
that
of immune
those
checkpoint is
patients, if you
something
did
you-
not give endocrine, then it's a detriment. So I would treat as TNBC, but after the chemo and this, I would
Immune checkpoint?
include
Yes.
endocrine.
Okay, immune checkpoint, yes, no.
Yes, I would.
So I have a contrary view, Sahu, ma'am, sorry, apology, I have a contrary view to you. See, in the ER positive, what we know is that achievement of PATCR is there, but whether that PATCR will convert into EFS, we don't know. That we know by the TNEO-BC and Kreuzer analysis, but whether that same thing of PATCR will be evolving into EFS for a hormone positive or even a low ER, we don't know. So the keynote 756 data where there is a 25% difference when we use Pembro and
So I think
PATCR, but whether that will convert into EFS, that 25%,
That's
till that doesn't convert into EFS, ma'am, I am not willing to
But,
add it into a low year.
I think this
The
is a
low
mixed bag of
ER,
patients
the
who
low
would
E-
be
the low
like
hormone
triple
receptor,
negative.
it was
Sharda has a
PATCR
point to
was
make.
75%. It was not. I mean, that's
I mean,
like
it's
a
a
TNBC.
retrospective analysis.
Yeah. So
I
I
have a
think
point to make. So we'll
No,
listen
sir,
to her.
just quick question, sir. In the previous this thing, if it's a low, it's a small tumor, how do you justify the axillary treatment that would be in addition? If it's an N0 patient, if it's an N0 patient upfront, our surgeons always tell us that we can get away by doing a sentinel lymph node. Now, if you give NACT, post NACT, they are not confident
No,
of
we are
doing
still
this.
okay doing SLN.
Post
I mean,
NACT,
I am not
SLS is
doing,
not,
my surgeon is definitely doing SLN.
The surgeon is answering here, if it is node negative to begin with,
That's not a problem.
you have by chance, you have ended up giving chemo because the medical oncologist kind of kept on hammering saying, let's give chemo. You will do a sentinel node biopsy even afterwards or a low axillary sampling and go by that. You will not do a clearance in this patient just
N1
because
to
chemo
N0
was
would be
given.
your
Node
other-
negative upfront. And there is evidence to that post neoadjuvant chemotherapy, N0 in previously, you can go ahead and conserve the axilla. But again, don't give the chemo then.
We'll take that in a surgical panel, N1 to N0, sentinel, I mean, all those things. So quickly on to that, we don't have any consensus. This is a mixed bag of patients who would, some would be treated like TNBC and some would be treated like ER positives. If it's a young 23, 24-year or 30-year-old female, we would treat her like triple negative. But the questions remain: carboplatin, yes or no, we don't know. Pembrolizumab, yes or no, probably in some patients. But how do we decide that? A lot of gray area around that, and we'll get more data to that, I think, in some time. Till then, it make our best judgment forward. Olympia, we have a 10-year follow-up now, and again, confirming this, some questions with the Olympia. Again, we'll ask Dr. Aparna about PAL-B2 and RAD51. Can you throw some light how mechanistically things would happen in BRCA1-2 and versus PAL-B2 mutations?
All right. So PALB2, I think, as the name suggests, it's a partner and a localizer of the BRCA2 gene. So they work in conjunction. Now, with respect to RAD51, I'm not really sure of its implications with respect to breast cancer. I think it's pretty well established in ovarian. So with our triple negative cohort or even your ER positive cohort, if you have a PAL-B2 germline or a BRCA mutation, I do think the implications are pretty similar. And we have tried it with some of our patients.
The bench says we could, but there's no trial evidence. How do you take that into clinical practice? Especially in adjuvant, would you offer? I mean, metastatic is a different place, but Dr. Smriti, ma'am, again.
Well, in the Olympia trial, they did not
They did
include
not.
them. But, well, you can discuss if it's a high-risk patient. I mean, suppose there is node positivity, high node positivity, but there is no evidence at all for PAL-B2 to receive adjuvant.
Because Olympia trial was actually
Adjuvant, no, metastatic, yes. I mean, I don't ask me the data, but yes, adjuvant, no, metastatic, yes.
So, Dr. Randeep, what the Olympia was, I mean, it's a huge trial with, such a rare mutation. The patients being so less.
have a trial with
So
PAL-B2.
many centers are being involved. What about PAL-B2? You are waiting for another trial.
No, is it a regular practice to do a HRR panel for a breast cancer patient?
This is not HR.
No, this is a broad, I mean, when you send a genetic panel, na, Rakesh, usually nowadays you cover all the, most of us don't do only
least PAL-B2
BRCA1,
is
2.
a
We do a
gene
broad
that
panel in
should
the
be
gene
covered
which
in
covers.
breast cancer.
We always do comprehensive.
I think we are sticking to
Why we do
BRCA1 and
it?
BRCA2.
Because how is very right to send only BRCA1, 2, don't get into confusion of sending a broad panel of RADs and PALB2s and RAD51.
That is different, but
PALB2 should.
And check 2.
P53, PALP2.
Check 2 also. Yes.
Careful.
Yes.
to
So
check.
we'll move to, I think in interest of time, we'll end or? Another interesting was, I think, antibiotic, but how do we take it into practice? We'll have to treat our febrile neutropenia patients. We cannot do justice. So do we stop our antibiotics early? Do we use single agent versus combination? Are you convinced that this data, there's also data from lung cancer, there's a meta-analysis, so we can't say that this is just 66 patient data. That's only in breast cancer. But I'll just show you the meta-analysis from lung cancer where it clearly shows that it's detrimental to have antibiotics. So how does it change our practice? We don't give antibiotics for viral infections. I think that's the only thing I take.
I mean, this
People
is.
would start, for URI, people are started on antibiotics, so I think that should clearly stop anyways.
See, this data in breast cancer, they didn't study the gut microbiome. So that was one thing. And second thing is, it's a very small subset and
66
needs to be actually studied prospectively. Now, if my patient gets neutropenia, which can be life-threatening, I wouldn't use this data and say I won't give the antibiotics. So we would use antibiotic judicially if, you're suspecting just viral fever and you don't want to give it. But if the patient is neutropenic, I wouldn't deny it based on this data.
Maybe what Sudeep sir was saying that don't give dose dense makes an importance here. Maybe I'm just a perspective that if you give dose dense, there are some chances of febrile neutropenia. So maybe with immunotherapy, just give 3 weekly.
Even with weekly Paclitaxel,
that is also dose dense. That is also you get febrile neutropenia.
Maybe delays because of febrile
Wonderful.
neutropenia.
I think we have to wind up this
unanswered
session.
question, and that's why we will have the 11th here in review next year. Thank you so much, our esteemed panelists, and thank you, audience, for your comments, engagement into the panel discussion.
I know the time's up and the comments are over and you're closing, but I just have one more comment as a surgeon. In all these discussions, of course, we never bring up the perioperative interventions, and one of our fellows from TMH suddenly sent me a message saying, what about those? We do have a significant DFS as well as an overall survival benefit by just using perioperative Proluton. And people forget that that was done irrespective, and triple negative definitely had a benefit in that. So if you're doing an upfront surgery, it's not harmful to do that. We go ahead with a perioperative Proluton and operate maybe at more benefit than even capecitabine.
Wonderful. Thank you for that comment, and thank you once again,
Thank you.
organizers and panelists. Thank you.